All right. Well, good afternoon, everyone. I have 1 p.m., so we will go ahead and kick off this month's APIC Great Lakes Educational Webinar Series. Great to see so many of you today. Thanks for carving out time to be here. Today's topic is hot topics in endoscope reprocessing. So again, I'm glad you can be here today. A few housekeeping announcements before we get started. As always, please just make sure you keep your line on mute and don't put us on hold. As much as we love your elevator music, we would really like to be able to use this time to do education. So we just ask that you don't put us on hold so we don't have to kick you out. If you have any questions for our speaker, feel free to use the chat box throughout the session. We will try to leave time at the end of the presentation as well to do some verbal Q&A. But in the event that we don't get to everything, we will compile them all and ask our presenter to respond and circulate those answers following the session. Another kind of APIC chapter update. Before we start, I just wanted to kind of put this on everybody's radar. As we normally send out emails following our education session, in this follow-up email that will come out following today's session will be an announcement with a survey link to let us know if you are coming to APIC Annual Conference in San Antonio in a couple of weeks. We want to make sure that we know all of our members who are there, who are presenting, whether it's an oral presentation or a poster. And certainly, please leave us your cell phone number so that we can make sure that we have you on a contact list so that when we convene for an APIC Great Lakes group photo, that you know when and where that will take place. So more to come, but keep an eye on your email in the next few days, but certainly in the next week, and let us know if you'll be in San Antonio. We are offering CEs for our session today, thanks to Healthmark. So please put your name and email address in the chat box. This is really, really important because we do not have a way to see who is on the call. Since this Zoom platform is managed by National APIC, we unfortunately can't get a list of attendees. So if you do not put your name and email address in the chat box, we cannot give you CEs. So again, name, email address in the chat box if you want CEs for today's session, and we can add a reminder at the end as well. But again, really important, if you want CEs, to put your name and email in the chat box. So with that, I would like to welcome and turn the podium over to John Whelan, who is the Clinical Education Specialist with Healthmark Industries, for today's presentation. And again, thanks to him and his team for providing CEs for all of our attendees on today's call. And with that, John, welcome. The floor is yours, and I will let you share your screen.
Thanks, Kelsey. Hi, everybody. And I had mentioned to Kelsey just a few minutes ago, you will be able to officially call this an international webinar because I'm sitting in a boutique hotel in Cartagena, Colombia. I came down here this last week to speak at a Central and South American Disinfection Sterilization Congress. And the trip is bookended by an extended family member's wedding this following weekend. So in the meantime, John booked a boutique hotel, which means everything is undersized and cramped usually. And if it looks like I'm sitting on a throne, it's actually the backboard to my bed here. So cross fingers that the internet holds, but it's been really good so far. I am going to go ahead and turn my video off while I do the presentation and share my screen. And Kelsey, if you can just verify as I do this that you can see my screen okay. 1 second here. Sorry, still adjusting screens. Here we go. Should be able to see my first slide, yes?
Yes. Yep, we can see it.
Okay, great, thanks. So this is the presentation on hot topics in endoscope processing. Just a little bit about my background. I know some of you already over the years, and it's great to see your names again. If any of you are going to San Antonio to the conference, I'd love to meet you in person. I'll be there with our company. I've been in healthcare quite a long time, and that's what happens when you start at age 5, right, in healthcare. My career as a nurse, 10 years in emergency. I was in endo for over 20 years. I was over 30 years at University of Michigan Health System. My last role at the health system was overseeing high-level disinfection endoscope processing for the entire system. So where I grew up knowing GI and pulmonary endo inside and out, it was that system role that really, similar to your firsthand experience, gave me the perspective on what's happening at a system-wide level and what's going on behind the closed doors of places like urology and ENT and respiratory therapy and that type of thing. I've been a member of various organizations over the years. Prior to my clinical leaving my clinical position 5 years ago, I was a member of AMI and still am a member of the work group that wrote Standard 91, ST 91 for AMI. So it's at this point, you can blame me or thank me depending on your perspective of that. So these are my disclosures. I am the employee of a manufacturer and distributor of medical products. I've not received any compensation for this presentation. This is not intended to serve as like a training guide or a promotion. And we always stress with our presentations before using any medical device, always read and follow the IFUs. It's the mission and the policy of Healthmark. It's more than just words, actually, and that's one reason I had choices as I left my clinical career, and having been a customer of Healthmark, it was an easy decision to make to join the clinical affairs education team because of the focus on gratis support with education, including presentations like this. And I really believe that there is a true commitment to educating the customers. These are the 3 objectives for the program: give you an update on the most current guidelines for endoscope processing, overview some of the latest hot topics in endoscope processing, and the future of sterilizing and other endoscope trends and technology. So as the years go on, the significance, the concerns about reusable device processing, notably flexible endoscopes, haven't diminished. As many of you know, one organization that monitors risk from medical devices is ECRI, ECRI. It's an independent international nonprofit organization, and it's considered an authority for medical practices and products. Their main focus is patient safety and risk reduction. To me, it's very interesting to note how this organization was founded. It was founded by a physician after an experience where a 4-year-old boy died after the defibrillator being used failed to work. So out of that horrific circumstance was born this organization that's now devoted to patient safety and risk reduction. So every year they publish top 10 lists of patient safety concerns. Not a good list to be on. Between 2013, 2018, reprocessing of flexible endoscopes was always listed, and it was #1 in 2016. I want to show you where that list has evolved related to reusable device processing over the last several years. 2018, endoscope processing was #2. At this point in 2018, ECRI was recommending establishing quality methods for monitoring and assessing the quality of the cleaning steps through magnification-aided visual inspection and the use of biochemical testing. So we're talking 6 years ago, and fast forward to today, many places still aren't there. They also in 2018 talked about implementing measures to dry endoscope channels after processing. Again, many institutions still trying to figure that out. Listed as #5 in their 2019 report, it was here that they emphasize issues with handling, storage, air drying, transportation of flexible endoscopes. So improper handling, storage can recontaminate, obviously, regardless of how well you cleaned or high-level disinfected the scope, you can recontaminate it if you do it inappropriately. To promote drying, they, as well as the relevant professional societies, recommended purging endoscope channels with clean air at the end of processing, even after the automated endoscope processor. They highlighted gloves used at this point. Gloves needed to be used at this point. And to remove the scope from the processing machine, as well as to transport the post-HLD scope. And that the transport should be in a clean enclosed container that's dedicated to that purpose. 2020, the list included these safety concerns: responding to and learning from device problems, device cleaning, disinfection, sterilization, standardizing safety across the system. Obviously, these don't specifically spell out flexible endoscopes, but they each speak to related processing and quality control. 2021, a little thing called COVID came along that impacted everything in the world as well as in healthcare. And post-COVID, we're acutely aware of the need to be prepared for such pandemics, because as you well know in your professions, it's not an if, but a when reality. COVID really ripped bare the weaknesses in the supply chains, especially problematic when it came to PPE. Again, I'm preaching to the choir on this, I know. Both clinical practitioners and reprocessing professionals, I think, received a wake-up call related to exposure risk too. Both endoscopy and endoscope processing are aerosol and splash generating procedures, and we need to be ever more vigilant in how we protect ourselves and our coworkers. For the 2022 list, supply chain shortfalls, duodenoscope processing made it on the actual top 10. And it's interesting to note about duodenoscope processing, the risk related or highlighted included obstacles to effective processing, like time pressures and poor work environment ergonomics. So it wasn't just the actual steps of processing, but how the processing was performed and the impact on the staff that did the work. 2022, ECRI also referenced what they called recurrent patient safety challenges, as you see at the top right of the screen. So these are issues that, even though they didn't make it to the top 10 list, we shouldn't forget these. They deserve sustained attention. As you see highlighted here, that include, not surprisingly, device cleaning, disinfection, and sterilization, and particularly highlighting reprocessing of reusable medical devices, reprocessing of flexible endoscopes, and instrument sterilization and disinfectant practices. For the 2023 list, recurrent challenges continue to include culture of safety, the infrastructure for safety, device cleaning, disinfection, sterilization, medical devices and supplies, and infection prevention and control. ECRI separately publishes an annual top 10 list of health technology hazards. For 2024, number 2 was inadequate or onerous device cleaning instructions endanger patients. ECRI highlighted what many of us are painfully aware: the wide variation in processing IFUs. They emphasize that healthcare workers who perform processing may find it difficult or impossible to complete the task effectively, or they may suffer harm in the process. They advised evaluation of reprocessing instructions prior to device purchase and implementation. Coincidentally, and important for this audience, realizing that infection preventionists are charged with monitoring cleaning adherence to IFUs in healthcare facilities, just 5 days ago, APIC published a report calling for the FDA and policymakers to have attention paid and help with IFUs that, in their words, rightly were convoluted, difficult, inefficient, and overly complex. So where should we be looking for guidance towards best practices? Well, in the United States, there's mandatory regulations as well as voluntary standards and guidelines. On the right side of the screen, you see examples from the common reference organizations. Starting from the top down, we're legally obligated to follow OSHA and EPA. It's the law. When it comes to the FDA and the CDC, you'd really be hard-pressed to justify not following guidance from them. Then we get into standards and guidelines from professional societies and standards organizations like ASGE, SGNA, AMI, and AORN. Accreditation and surveying agencies like the 2 examples I give here, there's more than this, Joint Commission, AAAHC, use all the above as their reference points. So within an institution, it really depends on your organization to identify by written policy who and what you hold your staff accountable to. For this presentation, I more commonly reference the Joint Commission as there's more information available, and I have more personal experience with their surveys. Remember too that standards and guidelines evolve over time, and this continues to be a work in progress. Oops, sorry, that advanced before I wanted it to. Besides AMI, AORN, SG&A, and ASGE, direction also comes from the FDA and the CDC, as well as accreditation agencies. So keeping in touch with professional societies and standards organizations is important. Similarly, it's important to stay informed as developments occur in between standards and guidelines being published, because they aren't renewed. The standards and guidelines don't come out fresh each year. What you see on the screen are a few examples from my personal experience where I was able to keep abreast of developments and stay up to date well before I got the flood of emails from administrators asking if we're okay at our institution or if we're going to be the lead story on CNN. FDA signing up for their safety communications allows instant access to new information. The CDC Health Alert Network that you're probably already aware of, their method of sharing information about urgent public health incidents. And these are both as easy as signing up for free and content-focused emails. In the US, especially on the heels of the many reported illnesses and deaths that were attributed and are to contaminated endoscopes, the Food and Drug Administration's paid increasing attention to endoscopes and endoscope processing. So again, the FDA safety communications are available by email to anyone. You can tailor the content. In this very timely way, you can stay current on critical information, again, in between standards and guidelines being updated. Let's just look at a couple relevant examples from the last few years. June of 2021, the FDA provided notice related to bronchoscopes. They reinforced following the manufacturer's IFUs to consider sterilization instead of high-level disinfection when feasible, and not to use damaged devices or bronchoscopes that have failed a leak test. That second part, doesn't it seem like somebody should not have to say that? But when you think of the reality of many endoscopy facilities and clinics just have enough inventory, no cushion of extra. So they may use things beyond points where they should. So they consider using a single-use bronchoscope in situations where there's increased risk of spreading infection, for example, multi-drug resistant microorganisms, immunocompromised patients, or patients with prion disease, or when there's no support for immediate processing of the bronchoscope. So for example, a bronchoscope used after hours when there is not any support for processing after hours. April of 2022, the FDA gave notice for significant reprocessing instructions change for some Storz brand urological scopes. 1 year prior, there was an FDA notice about patient infections and possible contamination issues with urological scopes. Further, reprocessing failures were identified after FDA requested validation testing from each endoscope manufacturer. So with this, it resulted in a voluntary recall by the manufacturer with an urgent field safety notice to discontinue high-level disinfection and low temperature chemical sterilization and sterilize instead. And the way it goes within institutions around the United States, for many places, they own their scopes, they do not lease them. So again, they keep them well past what you'd consider a normal lifespan. And so they may have older model scopes, including scopes like these. Also, April of 2022, the FDA provided an update to their safety communication about duodenoscopes from 2 years prior. As you see, this provided new information to support the transition to fully or partially disposable duodenoscopes. It also provided new information about completed post-market surveillance studies. Contamination rates for older models, the fully reusable duodenoscopes, were as high as 6%. One newer model with disposable components, the report at this time was that it was 0.5%. The direction here was that healthcare facilities should complete transition to the newer duodenoscopes. And as I route around the country, it's most common that most facilities already have. As they've done previously, the FDA took advantage of that same safety communication to reinforce the need for following manufacturers' IFUs, adhering to professional reprocessing guidelines, having a comprehensive quality control program, and having required documentation of training, competencies, and quality monitors. Now let's take a look at the predominant US standards and guidelines for endoscope processing from SG&A, ASGE, AORN, and AMI. Any healthcare organization needs to use a multidisciplinary approach to identifying which organization or organizations and documents they're going to reference in their policies and hold not just reprocessing staff to, but clinical staff as well. Within the last 3 years, each of the 4 major organizations that direct processing of flexible endoscopes have published new guidelines. This includes in order of publication, so reading from right to left, the American Society for Gastrointestinal Endoscopy, ASGE, the Association for the Advancement of Medical Instrumentation, AMI, the Association of Perioperative Registered Nurses, AORN, and most recently, the Society of Gastroenterology Nurses and Associates, SGNA. Key here is realizing that each of these replace existing publications. They are not simply updates or addendums. So for example, in your institution, if you say we follow SGNA and you are referencing in your policy the 2018 version, you are not up to date. And this presentation is not meant to be a replacement for individually reviewing the documents in full. Historically in the United States, SGNA had been the predominant driver for reprocessing guidance in the GI endoscopy realm. Many GI centers would focus primarily, if not all, on SGNA guidance. Shown here, the cover page of their standard related to processing of GI endoscopes. SGNA updated their endoscope processing standard just last year. ASGE, since 2003, they've been the principal organization behind what's called the Multi-Society Guideline that represents multiple professional organizations, predominantly GI physicians and nurses, as well as infection prevention. You'll note that AORN, APIC, and SGNA were supporting member organizations for the latest document. The latest version of this guideline, focused on GI endoscope processing, was published January of 2021. Especially for those of you that work in conjunction with ORs and surgery centers, you know that OR nursing staff tend to follow the AORN guidelines. AORN has their own documents and guidelines related to flexible endoscope processing. Their most recent guideline was published. ANSI is the American National Standards Institute. AMI is the Association for Advancement of Medical Instrumentation. The 2015 document was replaced by a 2021 version that was actually published the beginning of 2022. It's entitled Flexible Semi-Rigid Endoscope Processing in Healthcare Facilities. Remember, this is not an addendum to, but it's a replacement of the 2015 document. So this contains best practices for endoscope processing in any setting, where SGNA and ASGE especially spoke to predominantly the GI realm. This is for flexible endoscopes of any kind used in any setting or processed in any setting. It does not speak to TE probes or ultrasound probes, but the same work group that wrote ST91, as we were finishing the work on this, we realized that there was a paucity of information available when it came to ultrasound probes and dilators. So not probably a couple weeks ago, TIR 99, Technical Information Report 99, was published that speaks directly to those. A TIR is not a standard. It could eventually become a standard, but it helps to provide timely guidance on addressing ultrasound probes and dilators. So it's then necessary that healthcare organizations and frontline staff have access to the most current version of these references. and that your institutional policies and your practices reflect up-to-date recommendations. Accreditation and surveying agencies routinely ask which organizations are referenced, and then they survey to those. Useful then to know within your own organization is which standard or standards or guidelines are the reference points, and then what are the recommended expected practices from that. And whether one or several organizations are referenced is totally up to the organization. It's not required that only one organization is referenced. For example, where I came from, we referenced all the organizations, and where they differed, we spelled that out in the policy. When it comes to expectations for processing related policies, all the organizations are in sync with recommending that written policies for endoscope processing need to exist. They should be developed from a multidisciplinary approach, and staff need to be educated of those policies and have them available. Let's now look at current key concerns and recommendations through the various steps of processing. You see here the steps of processing as adapted from SG&A. These address the full cycle from clinical use through processing to storage. And again, it's an oversimplified list, but it basically includes all steps. It's going to look a little bit different when scopes are sterilized. Important points for the first step, point of use treatment pre-cleaning. It's now called point of use treatment to reflect all the work that's done at the bedside immediately post-procedure. We used to refer to it as pre-cleaning, but pre-cleaning is still done. It's just part of the point of use treatment. In pre-cleaning, it's that initial removal of organic material that's critical to make sure we decrease the bioburden load for the subsequent steps. Pre-cleaning has to occur because it's in the IFU, and it should be in your policies that it occurs. And it has to occur right as soon as possible after the procedure at the bedside in the procedure room. We need to follow all the steps of the IFU. We need to keep scopes moist for transport. That's an AMI recommendation. That's not new mentality when it comes to instruments and trays, but it is new thinking for flexible endoscopes. But the same rationale applies. You want to keep the bioburden from drying. And time is critical. We need to limit bioburden before it has a chance to dry and or biofilm has a chance to develop. So related, we need to have a method for communicating the time that pre-cleaning occurred to the processing staff so that we can then follow manufacturer's instructions for delayed processing. IFUs and guidelines for pre-cleaning at the bedside call for non-linting cloths or sponges to be used. Soil transport. So once the item's pre-cleaned, it's transported to a processing area. Depending on the institution, items may be transported first to a soiled room until eventual delivery to a processing area. It's OSHA guidelines that specify the need for and type of containment. Containment prevents contamination for staff as well as the environment. It also protects the device from damage. The container also needs to be appropriately sized and labeled biohazard. For any items that are sent off-site for processing, additional regulatory guidance from the Department of Transportation needs to be considered. Guidelines call for transporting contaminated endoscopes in puncture-resistant, hospital-approved containers with biohazard labeling. And remember, you have 1 hour to manual cleaning. This comes from the IFUs and it comes from standards and guidelines. Because of that potential for retained bioburden as well as biofilm development, there's a real need to limit that delay to processing. And again, to have a communication method to processing staff. So for example, Olympus calls for extended detergent soaking if there's more than 1 hour delay between pre-cleaning and manual cleaning. Currently, they have the most prescriptive direction. That's repeated in AMI and AORN's guidance. And realize in Olympus's reference, they speak to the 1 hour between pre-cleaning and manual cleaning, but they also talk about 1 hour between manual cleaning and high-level disinfection. So if you have a facility where they're staging scopes, staging them to get cleaned and then staging them after cleaning before high-level disinfection, you need to pay attention to the clock there as well. Leak testing occurs prior to manual cleaning. It's that opportunity to prevent both fluid and bioburden invasion inside the scope. Because through a hole, through a leak, not only can fluid get in to damage it, like you see in the middle picture there, but bioburden can get inside as well and may not come out until the next patient. For leak testing, there's manual and mechanical, as well as dry and wet methods for leak testing. And the key here is following every step of the endoscope and leak tester manufacturer's instructions and removing the endoscope from clinical use when a leak is detected. What you see on the screen are some common leak testing errors, including simply not performing this every cycle. For example, if a scope is overcoiled, if it's coiled too tightly, using a sink that's too small, leaks may not be discovered. We often see scopes not completely immersed in water or immersed in water that already has detergent added to it. So it's not uncommon to see staff going too fast or not taking the time that's prescribed to perform leak testing. Faulty leak testers are both a device and an infection risk. Not only can fluid get inside again, but bioburden can as well. So if the leak tester is not supplying adequate pressure, leaks can be missed. The leak tester may be making a noise. It may sound like something's working, but it may not be putting out a correct pressure. A common leak tester still in existence for those customers that have Olympus scopes is what you see in the picture here. It's a base unit, a pump, and a black cable. It's the Olympus MU1 and MB155 leak tester setup. The IFU for this says turn it on, and the part where it connects to the scope, there's a pin inside there. You depress it and you listen for a whoosh sound. But from one person to the next, what does that mean? There's no way to know how much PSI that represents. For many years, everyone expected, well, this is a piece of equipment, so biomed must check that. Well, all they've been able to do up till now is electrical safety testing. But now there are options for measuring, as you see in the picture, by attaching gauges. It's a very quick test, but it's a test that's recommended per AMI and AORN to be done every day that a leak tester is used. So manual cleaning, it's critical to use correct brushes. You do not have to use the same brand brush as the endoscope, but a brush needs to meet the specifications of the endoscope manufacturer. There is one brand of endoscope, Pentex, where they actually wrote into their IFU to use their brush, but otherwise it's fair game to use other brand brushes as long as you use the correct brush. And I often ask when I do site visits at facilities, how many times do you brush? The right answer is not a number. It's as many times as it takes, because each time you brush, you look at the brush exiting the distal end. If it's still dirty, you clean it off and you brush again, and you keep doing that until it comes out clean. So cleaning brushes should either be single use and disposed of, or reusable, and then each time receive high-level disinfection or sterilization according to their IFU. What's a perspective on automated cleaning in an AER? So the FDA says that manual cleaning and thorough brushing is required even when AER manufacturers claim that manual cleaning is unnecessary. That's a 2009 directive from the FDA. AMI ST91, recognition's given that there are some current generation AERs that have cleaning cycles that are validated and FDA cleared, but emphasis is that automated cleaning cycles don't replace or abbreviate point of use treatment at the bedside, and that if you consider replacing full manual cleaning with automated cleaning, or if you have what they now call modified cleaning at the sink, you as an infection preventionist should be part of a multidisciplinary team to conduct a risk assessment of your entire processes before you sign off on that. And when it comes to duodenoscopes, the FDA recommendations are reinforced that AER cleaning cycles are only a supplement to thorough manual cleaning. SG&A states the same, and they emphasize the value in that purposeful redundancy of having manual cleaning followed by automated cleaning. So the other thing that it's not uncommon that an infection prevention may or may not be aware of is whether the cleaning cycle is turned on in the AER. So automated endoscope processors, AER, have an automated cleaning cycle and an automated HLD cycle. It's worth validating whether you're relying fully on full manual cleaning at the sink, or if you're including automated cleaning in the machine. We emphasize that manual cleaning is the most important step in removing the microbial burden. To better ensure that cleaning was as effective as possible, we need to inspect the scope. All the major professional societies and standards organizations support the practice of using lighted magnification for inspection to go beyond what we can just see with the naked eye. As part of my role as an educator, we provide consultative reviews at facilities. It's one of the services we provide. And unfortunately, even in 2024, it's not uncommon to see no inspection occurring after manual cleaning. They say they're looking at it as it goes through, but we need to purposely stop and make sure that it's clean enough to keep going and not damaged. As we stated, any soil and/or biofilm that remains can interfere with disinfection or sterilization. So cleaning verification needs to be part of focused inspection. And cleaning verification, as the title implies, has to happen following cleaning and before disinfection or sterilization. You do not perform cleaning verification at the very end of the process. And as you see on the screen here, the predominant standards in professional organizations speak to the need to incorporate such quality control. AMI and AORN point out that high-risk endoscopes should have it performed every time. Non-high-risk endoscopes, the facility determines the frequency based on a risk assessment. But unless we look, we won't know. And unless we measure, we can't evaluate how we're doing. So quality control comes from complete inspection. Complete inspection involves using all the means available: basic visual inspection, enhanced visual inspection, borescopic inspection, and cleaning verification. Best practices include being aware of and keeping up with the expected steps of processing, as well as the risk in not following all the steps. All the current national standards are consistent in calling for active drying after processing, even after the AER. What's done in the AER is a purge of air. It's not meant to be a validated drying cycle, and the scope still remains coiled while it's lying in the AER. So anybody that's ever pulled a scope out of an AER knows that you hold it up and water drains out. So what we're talking about with the drying is external surface drying with low linting or lint-free cloths and having filtered air blown through the channels. So this should be outside of the AER, even when the AER has an air purge or extended dry time for AORN. So this needs to occur whether the scope is headed right to another procedure or whether it's headed to storage. It's important with any process to have some embedded quality control, at least periodically. How would you do that with drying? So there's what's called drying verification tests. Yes, you could put a borescope down the channel of a scope and look to see whether you have residual moisture, but then you'd have to reprocess the scope. The cards, that you see on the screen, it looks like a business card with the instructions. On the flip side is a blue coloring. You would hold that at the distal end of a lumen device, including a flexible endoscope, while air is blown through the channel. Any residual moisture would splatter white. It would change the card to white. So this is something I recommend to even infection preventionists to consider doing when they make rounds. If you use clean technique, clean gloves, clean technique, you don't have to reprocess the scope because you're just blowing air through the channel. When it comes to storage for flexible endoscopes, the important preface is that the scope needs to be dried first. And relevant guidance from AORN and AMI, drying cabinets are preferred, but if they're not available, and we realize that not all people can get drying cabinets, they're very expensive, then what's called conventional storage, which is vertical hanging storage that we've had for years, but the cabinet needs to have HEPA filtered air in the cabinet. I still find it at healthcare institutions where they have very nice looking laminate cabinets with passive airflow. Those days are gone, and this is not new information in the last few years. This has been for a while. There needs to be HEPA filtered air blowing into the cabinet. And you can't rely on hanging to dry the scope. When it comes to cabinets, you then also have an IFU from the manufacturer of the cabinet that you have to follow. Post high-level disinfection, endoscopes aren't packaged like sterilized scopes, so we can't rely on just looking at them to know whether it's been through processing. So a scope post-processing looks like a scope that was just pre-cleaned at the bedside. So what we need to do post-processing is clear visual identification on the scope to identify its post-HLD patient-ready status. There's multiple versions of how to do this, and you see examples in the picture there. Whatever product or practice you implement should be standardized across the institution. People often ask, which is the best one? The one that is best is the one that works. At the facility I came from, we standardized and educated to a green zip tie, like you see in the lower right picture. We made sure anybody that touched the process understood that green means clean and not to use a scope that didn't have the green zip tie in place. And we also created an expectation that the tie was put on so that it was in the way for the practitioner. They had to remove it. So it was in the way. And if it wasn't there, no questions asked, the scope wasn't used. Besides declaring post-HLD status, the physical identifier should include the processing date, the name or initials of the person who performed the processing, and the facility determined expiration date. So here in 2024, hang time is still variable. SG&A is the only organization still prescribing a certain number of days for hang time, 7 days, and they've done that for years based on a 2015 study that were research study. All the other organizations reference basing hang time on a multidisciplinary risk assessment. We earlier referenced the need to pay attention to the FDA safety communications. A significant example from 2015 addressed supplemental reprocessing measures for duodenoscopes. This is when they were giving guidance on the heels of what was happening with CRE contamination. So they referenced at this point microbiological culturing, ETO sterilization, use of liquid chemical sterilant processing systems, or repeat HLD. This is when a lot of people woke up to the idea of surveillance testing for flexible endoscopes. It wasn't commonly being done. It's still not done in large volumes, as I see going around the country. But this is where we evaluate the scopes after full processing. Just so you know, on the slide, the reason repeat HLD is in red and crossed out is because it's no longer in the FDA recommendations, because follow-up research has shown that it didn't really make a difference. There's recent studies out of Indiana where they routinely do double HLD. So the school is still somewhat out on that, whether that's the way to go. So when it comes to microbial surveillance, options include traditional culturing as well as gram-negative testing. It is not cleaning verification testing at this point, nor is it ATP testing. Surveillance testing looks for evidence of microbial contamination. This slide shows current guideline reference to microbial surveillance. And just so you know, I will make available PDF copies of this presentation. I may already have, but those will be available to you. For semi-critical devices, it wasn't intended that HLD was the one and only option, but rather if sterilization wasn't possible, then high-level disinfection. As we know, flexible endoscopes are heat sensitive, so they're not compatible with steam and other sterilization modalities. ETO sterilization, while it's compatible, is not available to many facilities, but there are sterilization options available though, especially for scopes used in surgical settings. Some key points when it comes to sterilization for flexible scopes. Remember, surgical scopes, many are compatible with vaporized hydrogen peroxide systems. You'll find STERRAD compatibility within the IFUs for Olympus. vPro often is not in the IFU, but it's in customer letters. ETO, again, compatible with all Olympus scopes. Sterilization is still dependent on adequate cleaning, drying, and device preparation. And then just like any other sterile tray, storage matters, so they need to be stored flat in wrap according to hospital policy. A significant update occurred in January 2018 when Olympus sent notice that they changed the IFU for this model, as you see on the screen here, of a common ureteroscope. They changed it to sterilization only. But the way this came through as a safety notice, it was a recall for these models because there were reports of parts of the scope coming off inside patients. So of course, people zeroed in on that and paid attention to that. They didn't necessarily pay attention to the fact that suddenly the IFU changed where reference to HLD was removed, and now what was stated was that sterilization was required. This is a really good example of how monitoring for the latest information and having the latest IFUs from manufacturers is so important. So how should we approach the discussion and the decisions about sterilization? At the very least, prioritization needs to be given to high-risk scopes, those that have been associated with infectious outbreaks, those that are difficult to process. So as per AMI and AORN, that includes bronchoscopes, cystoscopes, elevator channel endoscopes, so that's duodenoscopes, and linear EUS scopes, endobronchial ultrasound or EBUS scopes, ureteroscopes, and others. So a way to approach this, find out, first of all, who's got what scopes. Look at compatibility with sterilization methods that already exist within your institution. Any that can be easily sterilized, move them to sterilization. Look at your remaining scope inventory, and I give the example here of GI scopes. Prioritize by risk, so elevate your elevator channel endoscopes to high risk. Based on the FDA recommendations, for those high-risk scopes, do something else or something more. And you may need to adjust your inventory level of scopes. And I realize what a big ask that is, but this is where I truly believe from firsthand experience that infection prevention can be the advocate for patient safety and the need to consider the increased dollar amount of adjusting inventory levels. The last few years has brought technological advances to endoscopes themselves as well as their processing. So we already have semi and fully disposable endoscopes. There's an increasing number of endoscope drying modalities still coming out. Research and development is underway for low temperature sterilization and automated cleaning. There's products that are now under FDA review for those. There's an increased emphasis on bronchoscopes and other high-risk endoscopes, and an increased sensitivity and realization of aerosol and splash risk, both during the procedures as well as in processing. So I want to finish by looking again at this very oversimplified list for the steps of processing. When it comes to processing of reusable devices, proactive quality control involves doubling down on the best practices for each step in the processes. So if we aren't leak testing each time, we risk contamination for the scope, ineffective high-level disinfection or sterilization, infection risk for the patients that follow. If we're not completely cleaning, we again limit the success for HLD or sterilization. If we don't take the time for inspection, we miss the chance to catch damage or bioburden that would inhibit effective processing. And so that's purposely where we need to double down and double check and not assume. As far as the professional work of processing in healthcare, it's critical we maintain the same best practice approach, following guidelines from standards organizations and professional societies, as well as the FDA and the CDC. Sustained best practice comes from constant vigilance and seeking proven information from standards and guidelines organizations, professional societies, and peer-reviewed literature and research. This is my contact information, and I easily welcome any of your questions, both now and in the future. If there's any way we can help, any way that I can answer any questions or concerns that you may have. It's one of our services that I mentioned that we offer where we do consultative practice reviews. I only do HLD and endoscope processing because that's my background, but we have others that do SPD reviews. But it's an easy way to get another set of eyes on things. At the beginning of today's presentation, it was mentioned that you needed to enter your email in so you get your CEs. Actually, with the next slide here, I'm giving you access to your CE certificate, but I still need your email and name so that we can, in the event we get audited for providing CEs. So this is where you get your smartphone out and you scan this on the screen for your CE certificate. You see my contact information listed here. All you have to do is scan the QR code. What pops up is a screen where you enter your name and your email address, and then the C certificate comes to that. They give you a couple evaluation questions too. If you can't scan it for whatever reason, or you don't have your phone, I can send you the link or send you your certificate. So just email me at the email here. And it's at this point where I will turn it back, and I'll give it a minute here before you tell me to stop sharing my screen, okay?
Sounds good. Thank you so much. We'll just hold for a minute, let folks scan this, and then we can move into Q&A.
And it looks like we're okay time-wise.
Absolutely. We've got about 10 minutes. So as folks are finishing up scanning the QR code and processing your CEs, go ahead and think of questions. You're welcome to put them in the chat. Otherwise, in just a minute, we can open the floor for verbal comments and questions as well.
So I do want to mention at the conference that I came down here for, I was fortunately able to meet Tanya, your president of the organization, as well as Jessica, the executive director of CBIC, because they both spoke at the conference as well. And I had mentioned in the presentation about the APIC publication of a concern related to IFUs and their complexity and how problematic they are. They are definitely, Tanya mentioned that they're definitely looking for input from the membership and from anybody that knows anything or has experienced anything related to IFUs so that they can take this forward and hopefully make some changes or advocate for change.
Okay, so we do have one question from Rebecca.
Okay, I'll go ahead and stop sharing.
Across the US, we have so many new IPs. Even experienced infection preventionists do not necessarily have specific endoscope reprocessing hands-on training beyond education. Who is truly the best person to assess reprocessing competency?
Yep, that's not an uncommon question we get. AORN and Amy speak to more strongly than SGNA and ASGE do to promoting certification in endoscope processing. Just like we have certification, we have IP certification, we have nursing certification. There's endoscope processing certifications. The acronym initials are CFER and CER. I would recommend that even an infection preventionist consider that content. But beyond that, back to the question of who does the training and how do you make sure that they're valid? You need to have a super user, just like we do for so many other things. And that super user needs to be somebody that has advanced practice as well as additional education or training. And that can come from certification. It can come from attending conferences, focused presentations by endoscope manufacturers, that type of thing. So you're in AMI ST91, we made a point of writing in that not only should we focus on training and competencies for the frontline staff, but for anybody that educates or manages the process as well. We didn't directly say IPs, but based on the question, I would guess that's where they were coming from. Thank you.
Okay, thank you. I have another one. Another concern are staff who are placed over endo processing from OR settings that do not have background experience.
Yep.
This is a great risk given to the lack of resources and trainings.
Yep. And I definitely have seen that at multiple institutions where it's not uncommon that for one reason or another, and not uncommonly, it's that they want to have a director level position that may or may not be a nurse providing oversight to not just the OR, but to the processing areas of SPD and endo processing. They may not have a clue. They may not know anything at all about device processing. So I would really strongly advocate that within an organization, the case be made that people that oversee the work need to have They need to be able to freely delegate the oversight to people that have the background, or it needs to be people that have the background. And I'm not pie in the sky here and not unrealistic to realize that we don't impact the C-suite much of the time in terms of the decisions that are made. And we shake our heads many times at the decisions that come down from the C-suite, but it makes incredible sense that, like, why would you want to put somebody in charge of infection prevention and control at an organization that has nothing to do with infection prevention and control? It's that simple of an analogy.
Thank you. Another question we have, what are your thoughts on transport containers for scopes and probes?
Yep.
This facility struggles with their sterile processing with ensuring the containers are properly cleaned between uses. Vendors have TEE probe transport and storage containers with sheaths to move from a cabinet to bedside, then to sterile processing. Thoughts on ensuring how those are properly cleaned?
Yep. So the devil's in the detail with IFUs, and from one manufacturer to the next, they provide differing guidance on what can be used to clean and disinfect them. Not uncommonly, what I see around the United States is that reusable transport containers, unless it's an SPD area and they're able to go through a cart washer, it's more commonly to see surface disinfectant wipes as the only work, if you will, that's done after the scope is removed from them. To me, that doesn't make sense, and it's not enough. There should be cleaning followed by disinfection. There are disposable options available. Granted, not everybody can go that route, and there's sustainability concerns when it comes to that. One of the TE transport options that exist, and this is not John trying to talk down an individual product or manufacturer, but it's a clear tray that you can transport the TE probe in and put a sheath on the probe in the process. But if the container wasn't effectively disinfected, and I think that's the concern where the question's coming from, you potentially recontaminated it. So what we instituted where I came from, and what I believe is the best practice, is to have containers that are reusable or disposable. And for the reusable ones, they're cleaned as per the manufacturer IFU with detergent, followed by rinsing, followed by surface disinfection, or go through a cart washer. And for endoscopes, TE probes, and ultrasound probes, the cover doesn't need to be solid, but the sides and the bottom need to be solid for transport containers. The cover can be a plastic cover, as we've seen the red and the green covers, and depending on which direction you're going in. That's great to hear. I see in the chat that somebody's using their cart washer, which is awesome that they can do that.
Okay. Kelsey, if you could please share. That is it for questions. Thank you so much, John. We really appreciate you taking the opportunity to speak with us today. The information has been wonderful.
Take care, everybody.
Thank you. So please remember, all of our webinars are from 1 to 2 p.m. Eastern Standard Time. In June, we hope to see you in San Antonio for the APIC National Conference. And then in July, on the 16th, we will have long-term care NHSN reporting. So please mark your calendar so you can attend that webinar as well. Next slide, please. All sessions are recorded and will be available on the APIC Great Lakes YouTube channel. Later on this week, we will send out an email which will have the link with the slides and the link for the YouTube channel. So please make sure you bookmark those so you can reference them in the future. Next slide, please. If you have an open position and you would like to post it to the APIC Great Lakes webpage, please email our webmaster, Rebecca Batches, using the APIC Great Lakes Gmail. And then she can put the link to a job board and spread the word among all of the APIC Great Lakes members. Next slide, please. Thank you so much for joining us today. We really appreciate you and all of the work that you put in every day to make patient safety. So with that, we are going to close the webinar. Thank you.